I think still the most important point is the clinical picture of the patient. So you look at the patient, take a careful history of the patient to see, to learn about the symptom duration, the heaviness of the symptoms. For example, like severe shortness of breath or a recent syncope are known risk factor for a bad outcome of the patient with acute PE. For example, the blood pressure. Patients with rather low blood pressure have a higher risk. Also patients who are tachycardic, let's say a heart rate of more than 100 or 110, those patients carry a high risk of death, early death. Or patients who have really who are hypoxic, and this is easily measured by an O2 set of less than 90% on room air when they come in. And of course there's more to the picture. So we look at imaging tests, and nowadays we perform CT scans with contrast to see the clot burden of the patient. Of course, patients with segmental or subsegmental PE we usually do not treat with catheter intervention. The patients we favor for treatment are those with centrally located clots, so main pulmonary artery or proximal lower lobe pulmonary artery. And most of the patients have bilateral disease. I would say about 80 to 90% of the patients have bilateral centralized pulmonary embolism. And of course there's more to risk stratification of the patients. One of the key tests we use is the troponin test. It's a quite sensitive test, so in patients who have a normal troponin test, they usually have a good outcome, and typically we do not treat those patients with catheter treatment. And also we look at the right heart size. That's very critical actually, because especially RV-LV ratio is a parameter which is easily to obtain. You can already see it on the CT scan very well. You cannot really estimate a systolic function of the right ventricle, but you see the dilation of the RV. You see also the compromise to the left ventricle, and this is easily measured by the RV-LV ratio. So if this is greater than 1, in addition to a troponin that is elevated, plus the clinical features of the patient that fit into this picture, those patients are being treated with catheter directed thrombolysis, and actually in Zurich we use exclusively the ecosystem, because we don't have clear data for conventional catheter directed thrombolysis for this indication, but we do have at least some controlled studies for the ecosystem. Patients who have clear symptoms of PE, which is usually shortness of breath, maybe even a collapse or syncope in the last day or two. Patients who have right ventricular dysfunction or dilatation, ideally combined with a positive troponin test. And of course, patients should have not an absolute contraindication to thrombolysis. There's a few patients that cannot receive thrombolytics. For example, patients with recent neurosurgery, or maybe patients who had an intracranial bleeding in the past are clearly no candidates for treatment. But we have patients who have, let's say, a moderate risk of bleeding, like, for example, a patient who had hip surgery 3 days ago and comes with a severe pulmonary embolism, and those patients we treat also with the ecosystem. We may reduce the dose. I'm a big fan of using the fixed dose of 20 milligrams over 15 hours that we also use in the Ultima trial. But we sometimes decrease the dose even as low as 10 milligrams over 15 hours, or we may place just one device and use the 10 milligram regimen in patients with, let's say, increased risk of bleeding.